Welcome to The Explainer. Today, we are going to tackle one of the most common electrolyte disorders out there, but we're going to do it a little differently. You're going to be the one in the driver's seat, solving this clinical puzzle. So let's start with a number that really sets the stage here. 30%. Up to 30% of some hospitalized patient groups have hyponatremia, or low sodium. So yeah, this is not some rare, obscure thing. It's a daily challenge. But this isn't just about a number on a lab report. It can be life-threatening. And here's why that is. It's a really big deal because your body's water and sodium balance, it directly impacts your brain. So when that gets thrown off, the consequences can be, well, pretty severe. And I'm not talking about just feeling a little off. We're talking about some serious stuff here. Vomiting, seizures, severe confusion. I mean, it can go all the way to respiratory distress and even coma. This is what's known as hyponatremic encephalopathy, and it happens when the brain starts to swell. Scary stuff. All right, let's get hands-on. Here's your first case. Imagine you're the doctor on call. A 70-year-old patient is admitted. They're feeling really confused, really weak. You run some labs, and yep, just as you suspected, their serum sodium is low. So the big question on your mind is, what's causing this, right? Because hyponatremia isn't really the diagnosis, it's a clue. To solve this puzzle, we're not going to guess. We're going to follow a really slick 3-question diagnostic algorithm to get to the bottom of it. Okay, here's our roadmap for this whole investigation. It's a 3-step process. First, we'll look at the serum osmolality. That tells us if this is true hyponatremia. Then, we check the urine osmolality to see if the body's trying to hold on to water. And finally, we'll look at urine sodium to figure out the patient's volume status. Let's do this. All right, clue number 1 is in. The lab calls back. The patient's serum osmolality is 265. So looking at that number, what do you think? Is this isotonic, hypertonic, or hypotonic hyponatremia? If you picked C, hypotonic, you are absolutely right. A normal serum osmolality is somewhere in the ballpark of 275 to 290, so 265, that's definitely low. And this is a super important first step because it confirms we're dealing with what we call true hyponatremia, a genuine excess of water compared to solutes. Okay, on to clue number 2. The urine osmolality comes back at 450. Now think about this for a second. The body has too much water. So what does a number like 450 tell you about the hormone ADH? Is it being suppressed or is it active? And the answer is B. ADH is active, and this right here is the heart of the problem. See, normally in a state like this, the body should be screaming, stop ADH, to get rid of all that extra water. We should see really dilute urine, like less than 100. But 450, that's concentrated. It tells us ADH is on, and it's making the kidneys hold on to water they desperately need to get rid of. All right, time for our final piece of the puzzle. Clue number 3. The urine sodium is 60. So what does that tell us about the patient's volume status? Are we thinking their volume down, volume normal, or volume up? You got it. The answer is B, euvolemic. This means their volume is pretty much normal. Think about it. If they were dehydrated, their body would be in panic mode, trying to hold on to every last bit of sodium, and that urine sodium would be super low, probably under 30. But 60 tells us the kidneys aren't trying to conserve sodium, which points us right to a euvolemic state. Okay, let's put it all together now. What have we figured out? 1, we've got a case of true hypotonic hyponatremia. 2, we know that ADH is active when it absolutely shouldn't be, causing the body to retain water. And 3, we've ruled out volume depletion as the cause for all this, since the patient is euvolemic. So, when you line up all those clues, what's the diagnosis? It's the classic textbook case of the syndrome of inappropriate antidiuretic hormone secretion. You might know it as SIADH. And basically what's happening in SIADH is exactly what the name implies. The body is releasing ADH inappropriately. It's not because of dehydration. It's not because the blood is too concentrated. It's just on. And that rogue ADH signal makes the kidneys hold on to pure water, which then dilutes all the sodium in the body. You know, the key takeaway here isn't just the final diagnosis, it's the process. It shows how powerful a systematic approach can be. Instead of just guessing, you ask 3 specific questions in the right order, and this really confusing picture suddenly becomes crystal clear. It's like you're uncovering the root cause, step by step. So, we've solved the puzzle. We've figured out what's going on. But that leads us to a final, and honestly, a really critical question. Finding the cause is one thing, but what's the biggest risk when you start treating this condition too fast? That's a whole other can of worms, and maybe a puzzle for another day.